Hello, my name's Delmy Luff. I'm an Anaesthetic Registrar at Queen's Medical Centre, Nottingham, and today I'm going to be talking you through a landmark Fascia Iliaca nerve block. Neck of femur fractures are the most common serious injury seen in older people, and the pain can be severe. With multiple chronic medical comorbidities being common amongst elderly people, pain management can be difficult. Unfortunately, this can often mean that it is suboptimal. We advocate regional anaesthesia in such patients, as it will reduce the amount of strong opiate analgesia which is required, which can have significant side effects in the elderly. It will also produce a dynamic analgesia, which is not present with opiates, which will allow routine nursing care on the ward. This should last between 24 and 48 hours, so we recommend that all patients that present with a fractured neck of femur should be considered for early fascia iliaca nerve block before theatre. The landmark fascia iliaca nerve block is a relatively easy and safe procedure to perform. It has an excellent record for multi-specialty administration, has a rapid onset, and can be performed in a supine patient with minimal repositioning. It also has the benefit of not requiring any special equipment such as nerve stimulators or ultrasound machines, which allows it to be quickly and easily performed either in A&E or on the wards. Sensory nerve supply to the hip joint is provided primarily by the femoral nerve. However, it also gets additional supply from the sciatic nerve and the obturator nerve. As you can see from this diagram, the femoral nerve passes underneath the inguinal ligament lateral to the femoral vessels. There are two important fascial layers that allow the fascia iliaca nerve block to be performed. The femoral nerve and the femoral vessels all lie beneath a superficial fascial layer called fascia lata. However, the femoral nerve is separated from the femoral vessels by a second, deeper fascial layer called fascia iliaca. When performing a landmark fascia iliaca nerve block, the needle first passes through the skin. As you advance your needle, it will pass through the fascia lata and you will feel a first pop. As you advance your needle further, it will pass through the second fascial layer, fascia iliaca, and you will feel a second pop. This is where you stop and inject your local anaesthetic. It should then spread underneath the fascia iliaca, surrounding the femoral nerve, anaesthetizing it. I'll now talk about the practicalities of actually performing the block. I'm going to split it up into preparation, performing the block, and aftercare. Patient selection. We would primarily recommend that the landmark fascia iliaca nerve block is used for patients that present with a fractured neck of femur. However, it could also be used in patients with femoral shaft fractures. There are relatively few contraindications to a fascia iliaca nerve block. Absolute contraindications include patient refusal, if they have the capacity to do so, a known sensitivity to local anaesthetic, or infection at the site of needle insertion. Relative contraindications include anticoagulant use or a known coagulopathy, previous femoral vascular surgery with atypical femoral artery anatomy, or an inability to palpate the femoral artery. These patients may benefit from a block performed under ultrasound guidance. Full informed consent should be obtained in patients who have capacity to do so. The main benefits to explain obviously would be analgesia and also the avoidance of excessive opiate analgesia, which can have significant side effects. The main risks, which are very rare, would be bleeding at the site of puncture, infection, viscous puncture, nerve damage, failure of the block, and in very rare cases, local anaesthetic toxicity. In our hospital, we have developed a nerve block sticker to help you document your block. This should be completed and placed on the front of the patient's drug chart. At the top, you can indicate which block you have performed. The left-hand column has a pre-block checklist and space for a pre-block pain score. The middle column has a space to document the block, including the local anaesthetic used. And the right-hand column has space for post-block observations and a post-block pain score, which can be used to determine whether or not the block has been effective. With your patient consented, it's now time to prepare your equipment. You'll want to prepare a sterile field, onto which you'll now want to open your equipment. You will need a pair of sterile gloves, one 20mm and one 10mm NR fit local anaesthetic syringe, one NR fit drawing up needle, one 80mm NR fit Stimuplex nerve block needle, 30 ml of 0.25 levobupivacaine. The maximum safe dose of levobupivacaine is 2 mg per kilogram, so 30 ml of 0.25% levobupivacaine would be a safe dose for all patients over the weight of 38 kilograms. You will also need some 2% chlorhexidine to clean the skin. You may want to use a sterile drape to help maintain an aseptic non-touch technique, however this is optional. You should have some gauze in case of any bleeding, an adhesive dressing to put on at the end. You should have standard monitoring and resuscitation equipment available, and the patient should have IV access and IV fluids prescribed. Next, you'll want to wash your hands and put on your sterile gloves. Using the drawing up needle, you'll next want to draw up 30 ml of 0.25 levobupivacaine into your 20 and 10 ml NR fit local anaesthetic syringes. Next, you'll want to attach your block needle and make sure it's flushed through with local anaesthetic. One of the benefits of a fascia iliaca nerve block is that it can be performed in a supine patient. You'll want to expose the inguinal region whilst maintaining the patient's dignity and warmth as much as possible. You may find the block easier to perform if the leg is slightly abducted. You are now ready to perform the block. You'll want to start by cleaning the skin with 2% chlorhexidine. Now you'll need to identify your surface landmarks. These are your anterior superior iliac spine, your pubic tubercle, and between the two lies your inguinal ligament. Next, divide the inguinal ligament into thirds. The needle insertion point is 1 to 2 centimeters caudal to the point between the first and second third. You can now mark this point by applying gentle pressure with your needle cover. To help avoid accidental vascular puncture, palpate the femoral pulse medial to this point. You should now perform a stop before you block check. Stop Before You Block is a national campaign which aims to prevent wrong-sided blocks, which are now considered never events. Immediately prior to needle insertion, you need to check that you are blocking the correct side. This can be done by visualizing surgical arrows which have been drawn on the patient, asking the patient to confirm which side they have injured, and double-checking the consent form which has been previously filled out. You should now be ready for needle insertion. Warn the patient, then carefully insert the needle 90 degrees to the skin. Slowly advance your needle, feeling for the 2 pops as you pass through the 2 fascial layers. After you feel the second pop, stop advancing and stabilize your needle. Next, aspirate your syringe to make sure you're not in a blood vessel. You can now inject your local anaesthetic 5 ml at a time, stopping to aspirate in between each 5 ml. This is to check that the needle hasn't migrated into a blood vessel. Once you have administered 30 ml of local anaesthetic, carefully remove your needle and apply a sterile adhesive dressing. You'll next need to carefully dispose of your sharps and any other waste. The patient should now be monitored for the next 30 minutes. Basic observations should be recorded every 5 minutes for the next 15 minutes. A pain score should then be taken after 30 minutes to see whether or not the block has had any effect. This can all be documented on the yellow sticker we have previously discussed. If after 1 hour there is no improvement in the patient's pain, it is highly likely that the local anaesthetic has not reached its desired target. In these patients, we recommend either considering alternative analgesia or contacting another practitioner, an A&E senior or the on-call anaesthetist to consider repeating the block at half the dose. It may be beneficial for this repeat block to be performed under ultrasound guidance. Local anaesthetic toxicity is a rare but life-threatening complication. It usually results from going over the maximum safe dose for that particular local anaesthetic or accidental vascular injection. You should have a high index of suspicion for local anaesthetic toxicity if your patient starts to develop any of the classical cardiovascular or neurological signs and symptoms. Initial signs and symptoms have an excitatory nature. However, as it progresses in severity, these symptoms become depressive. If we think about the neurological symptoms first, during the initial excitatory state, the patient may complain of perioral tingling, tinnitus, slurred speech, lightheadedness or tremor, and this may progress to generalized convulsions. In the inhibitory state, the patient's GCS might start to fall and they may eventually develop respiratory depression. If we now think about the cardiovascular symptoms, during the initial excitatory state, the patient may become very hypertensive and tachycardic. As things become more serious and progress, this could become myocardial depression, hypotension, and eventually arrhythmias. Management of local anaesthetic toxicity is largely supportive in nature. You want to make sure that you've stopped injecting your local anaesthetic, you've called for help, you've given the patient 100% oxygen, and then you continue to support the patient by following basic and advanced life support algorithms. In the rare severe reactions or in the event of cardiac arrest, you will need to give the patient an intralipid infusion. In our hospital, we have yellow local anaesthetic toxicity emergency boxes which contain all the drugs required to treat severe reactions as well as guidance on how to administer intralipid. Though this is a serious complication, I think it is important to remember that it is rare and it should not deter you from performing regional anaesthesia for patients that present with fractured neck of femurs. So in summary, the fascia iliaca nerve block is a relatively easy and safe procedure to perform and can significantly reduce morbidity in elderly patients. Therefore, we recommend it is considered for all patients that present with neck of femur fractures pre-theatre.